Guys, today we will be revising gynecology, so we'll do it really rapid, really quick. So we'll start with menstrual cycle. Okay, so menstrual cycle, initially hypothalamus gives feedback to pituitary gland. It releases GnRH. Then pituitary gland releases LH and FSH and stimulates the ovary. Ovary releases estrogen, progesterone, and then it gives positive feedback or negative feedback depending on the days. Okay, so there are two phases, proliferative phase and secretory phase. Proliferative is also known as follicular or estrogenic phase, and secretory phase is also known as progesteronic or luteal phase. Okay, so we've already said that hypothalamus secretes GnRH, but in a pulsatile fashion. It acts on in anterior pituitary. Now it secretes both FSH and LH. FSH is secreted once in 90 minutes, so it is a low frequency pulse, and LH is secreted once in 60 minutes, so it's a high frequency pulse. We can also learn this because LH is particularly required to rupture the follicles, right? FSH is helping in growing the follicle, but for the rupture, LH is required, so you need a high frequency pulse. Okay, just a way to learn. And which is secreted first? FSH, because we need the follicles to grow first, only then it can rupture. So FSH acts on ovarian granulosa cells. Ovarian granulosa cells releases estradiol and inhibin B, which gives negative feedback to FSH. Okay, so inhibin B, from the name itself we understand it's inhibiting, so it's giving negative feedback to FSH. Okay, and what does estradiol do? Now we'll learn about the mainly. Okay, so FSH, when it acts on ovarian granulosa cells, it mainly releases estradiol and some amounts of inhibin B. So estradiol actions are, it increases LH. Okay, so FSH is acting on ovarian granulosa cells, it is releasing estradiol, and estradiol is releasing LH. So FSH is kind of required for increasing the LH, right? So talking about LH gives positive feedback only before ovulation, otherwise it is giving negative feedback. So overall LH is giving positive feedback. Okay, now it also causes proliferation of endometrial glands. Estradiol, we know estrogen causes proliferation of endometrial gland, causes thickening because it is preparing for the pregnancy, right? And it gives negative feedback to FSH. So both inhibin B and estradiol gives negative feedback to FSH. Negative feedback, okay, to FSH. Okay, now so there is a pool of follicles available for the reproductive period, and every month follicles are recruited from that pool. This is why with advancing time follicles are utilized in their number, which starts decreasing, and when the follicles are exhausted, the women approaches menopause. So every month 6 to 7 follicles are recruited, and among that one will mature. So yeah, so many follicle grows and it secretes estradiol. So now once the follicle grows, the work of FSH is done. So now estradiol will start giving negative feedback to FSH. Okay, so the hormone, now which hormone we require? The hormone required is for rupturing the follicle, because the growth is already done, so LH is required. So now estradiol increases the LH. Estradiol gives positive feedback to LH. Okay, now once dominant follicle is attained, what's the size of the dominant follicle? It is 14 mm. Dominant follicle is 14 mm. After that, what happens? There is an FSH surge. Okay, even though there is a negative feedback to FSH being given, once there is a final push which occurs from prostaglandin secreted by granulosa cells from the action of LH. We'll come to this, just I'm giving you an overview. So the final push, FSH surge, will make the size into 20 mm, and this is the size of the mature follicle when it has attained 20 mm size. So dominant is 14, mature is 20. Okay, now follicular growth pattern. Initially many follicles grows. As soon as one follicle attains 14 mm size, other follicle starts regressing, that is atresia. Now so that's the dominant one. Like now this is dominant, rest all are not dominant. Okay, so they will regress, and the dominant one will now be decided to become mature. Okay, so selection and growth of dominant follicle occurs on day 8 of cycle due to FSH. Okay, because we know the growth is due to FSH, so obviously selection and growth of dominant follicle will be due to FSH. What you need to remember is on day 8. Okay, now follicular growth per day is 2 mm per day. Size of dominant follicle is 14 mm. Like, okay, sometimes people can think it's not 14 mm is the best option for size of the dominant follicles. Mature follicle is 20 mm. Follicle ruptures at 20 mm when it has become mature, right? Now actions of LH. Estradiol was giving positive feedback to LH, right? Okay, so LH. Ovulation occurs by LH surge and LH peak. Rupture of follicle is known as ovulation. LH surge is due to estradiol because, as we said, estradiol was giving positive feedback to LH, so there was an LH surge, sudden release of LH. Now, when does LH surge happen? LH surge, the best possible option is 36 hours. If there is no such option, then you can do 32 to 36 or 24 to 36. Best option is 36 hours, okay? So 36 hours before ovulation. Before ovulation. Obviously, after ovulation, what's the purpose of LH surge? For the ovulation to occur. So it is 36 hours before ovulation. Now, LH peaks is LH surge and LH peak. They are two different things. So the rise is known as LH surge. This will occur 36 hours prior to ovulation. Now, after LH surge, we attain LH peak, right? So this is 12 hours prior ovulation. Okay, so LH peak is attained 10 to 12 hours before ovulation when minimum amount. So at this point, there is a minimum amount of LH required for ovulation, that is known as LH peak. A minimum amount of LH required for ovulation is 75 nanogram per ml. Okay. I'll repeat again. Ovulation occurs by LH surge and LH peak both. So LH surge occurs 36 hours prior to ovulation, and then is LH peak, which occurs 10 to 12 hours prior to ovulation, and the minimum amount of LH required for LH peak is known as, for ovulation, is 75 nanogram per ml. 75 nanogram per ml. 1 nanogram is 10 to the power 9 grams, just so you know. Okay, now the first function of LH was ovulation by LH surge and LH peak. Now second function, LH acts on theca cells. What does this theca cells do? We'll little bit study from here. The ovary has two cellular components, theca cells and granular cells. Theca cells expresses receptors for LH, and granulosa cells expresses receptors for FSH. Okay. Now, LH stimulation of theca cells leads to production of androgens. LH is stimulating theca cells, as we said here. LH is stimulating theca cells leads to the production of androgens. What are the androgens? Testosterone and androstenedione. Okay. Now, FSH stimulation of granulosa cells causes the conversion of these androgens to estrogens, which is estradiol and estrogen. Okay, CC. LH is stimulating, acting on oh my goodness. LH is acting on theca cells, which releases cholesterol, and FSH is acting on granulosa cells, which causes the conversion of cholesterol is androgens, right? Androgen to testosterone by granulosa cells by aromatization. Now, at this point, we have estradiol, which is converted to estrogen. So, what do we learn is that aromatization is occurring in FSH. See this question. According to the two-cell gonadotropin theory, which hormone stimulates the conversion of androgens to estrogen in granulosa cells? So it is FSH, not LH. LH is acting on theca cells to release androgens, but the conversion of androgens to estrogens or cholesterol to estrogens is occurring in granulosa cells via FSH. Okay, so this is the two-cell gonadotropin theory. Now, which hormone? Aromatase enzyme. Okay. And this is maximum in adipose tissue, so obese female has more estrogen due to more aromatization, right? And aromatization is occurring in granulosa cells. Okay, now LH also acts on granulosa cells before the day of ovulation. So what will this granulosa cells do? This granulosa cell will secrete small amount of progesterone, and this small amount of progesterone will give positive feedback to FSH and LH, mid-cycle surge. So this is what we were talking about here. The FSH surge which was happening, it was due to progesterone which was secreted by granulosa cells from the action of LH, not FSH. Okay, FSH has already done its work till dominant follicle until the size is attained. Now there was a negative feedback. So now the surge is happening due to progesterone, which is released from granulosa cells again. Okay, so estrogen was also released from granulosa cells. But now we're talking about the progesterone which is released from the granulosa cells, but from the action of LH. So, yeah. And small amount of progesterone. So, increases FSH and LH mid-cycle causes surge. Now, which helps in ovulation. So, ovulation occurs mainly due to LH, but also due to FSH. So, the best answer will be both. Now minimum estradiol required for LH surge is 200 picogram per ml. Okay, here what we talked about, it was, okay, I'll write it here, it will be better, due to estradiol, right? And minimum estradiol required is 200 picogram per ml, right? Which should be sustained for 48 hours. Sustained for 48 hours. Now we have how many time numbers and how many amount. So we have 36 hours, we have 10 to 12 hours, and we have 48 hours. Okay, so LH peak is 12 hours prior ovulation, LH surge is 36 hours prior ovulation, and the minimum estradiol should be at least of 200 picogram per ml, should be sustained for at least 48 hours for the LH surge to occur. Okay, so at least for 48 hours, like, okay, you can say this much should be 48 hours is at least required for, and how much amount? 200 picogram per ml. Okay, now the amount, talking about the amount, so minimum estradiol required is 200 picogram per ml, and minimum LH required for ovulation is 75 nanogram per ml. Picogram is 10 to the power minus 12 gram, so it's even lesser than LH. All right, so minimum estradiol required for LH surge to occur is 200 picogram per ml, and minimum estrogen, that I said, minimum estrogen required for LH surge to occur is 200 picogram per ml, sustained for at least 48 hours, and minimum amount of LH required for ovulation is 75 nanogram per ml. Now, moving on. Okay, after ovulation, ruptured follicle is known as corpus luteum, which is yellow due to lutein pigment or carotene pigment. Ruptured follicle is yellow due to carotene pigment. Carotene pigment. Do not think carotene is red. It's a yellow pigment, lutein pigment. Okay, at ovulation, secondary oocyte is released from ovary. At ovulation, this question will be asked, secondary oocyte is released at what time? At ovulation time. Okay, from ovary, corpus luteum is supported by luteinizing hormone, LH hormone. Pregnant corpus luteum, however, is supported by HCG. Then we have maximum size and activity of corpus luteum on day 8 is on day 8 post ovulation. Okay, day 8 post ovulation. And if you remember, this selection and growth of dominant follicle is also on day 8 of cycle. That is of cycle, and that is post ovulation. Okay, so that becomes almost 22 days if there is a 28 days cycle. So yeah, and minimum levels of FSH and LH are on day 8 post ovulation. That is why it makes sense, because until LH is there, the size of the corpus luteum, once the LH is over, like it completely finishes, so now the corpus luteum will start regressing, right? So there is no one supporting the corpus luteum, because corpus luteum is supported by LH. And why is FSH and LH decreasing? Because of the negative feedback of progesterone and estrogen. Now, estrogen gives negative feedback to FSH. We all know that. Progesterone gives negative feedback to LH. Now, we'll question that how is progesterone causing FSH and LH? That's a small amount of progesterone. That's why. Okay. So, and the maximum negative feedback is on day 8. Progesterone activity is maximum. So, it gives maximum negative feedback to them, LH. And so, the LH depletes. Corpus luteum starts regressing. Okay. Now, one thing to remember is that, what did we say? That corpus luteum is supported by LH hormone, right? For how many days? It is 10 to 12 days. But the pregnant corpus luteum is supported by HCG, but before that, it is supported by LH for 10 to 12 weeks in case of pregnancy. a little correction. I just checked. So lifespan of pregnant corpus luteum is 10 to 12 weeks, and lifespan of non-pregnant corpus luteum is 10 to 12 days. Now why was this? Because of the luteoplacental shift. Okay, let's read this out. Corpus luteum secretes various hormones which are estrogen, progesterone, relaxin, inhibin A. Progesterone holds endometrium, right? We all know that. Maximum activity of corpus luteum and progesterone is till 8 days after ovulation. We already discussed this. After ovulation, there is a negative feedback to LH from progesterone. Now, LH was earlier supporting corpus luteum before negative feedback. After this, corpus luteum regenerates, and so the hormone being secreted declines, leading to menses, as progesterone no longer holds the endometrium. Because LH was supporting corpus luteum and corpus luteum was releasing progesterone, and progesterone was supporting endometrium. Now what is happening? This is giving negative feedback. So this will decrease, this will decrease, this will decrease, and then this will decrease. Okay. So after fertilization, there is no endometrial shedding, as pregnant corpus luteum is now supported by hCG, which is secreted by cytotrophoblast. But this is also till 10 to 12 weeks, because after 10 to 12 weeks there will be luteoplacental shift. Corpus luteum will degenerate after 10 to 12 weeks in case of pregnancy, because now the placenta will take over. Now corpus luteum secretes 3 hormones in non-pregnant female, which is estradiol, progesterone, and inhibin A. We discussed this. Secretes various hormones. This relaxin was in pregnancy only. Okay. And predominantly corpus luteum secretes predominantly progesterone. Yeah. And corpus luteum secretes inhibin A, not inhibin B. Inhibin B was secreted by ovarian granulosa cells, which was giving negative feedback to FSH. Okay. Now, so one thing is common. Estradiol is secreted by both ovarian granulosa cells as well as corpus luteum, but inhibin A, not B. Okay. And one extra hormone is relaxin in case of pregnant females. Actions of progesterone support, hold, stabilize, maintain endometrium that has already grown up. Now, what is the function? Secretion of glycogen lipids, which are stored in tiny numerous vacuoles in liquid form. So this is the earliest histological feature of secondary endometrium. What you will see, so you will see subnuclear vacuolation. This question will be asked. Earliest histological feature of secondary endometrium, which is secondary vacuolation, or the question will be subnuclear vacuolation is seen in which phase? So it will be progesteronic phase. What is the function? It provides nutrition to the fertilized ovum. Now, after 2 to 3 days, the vacuoles become heavy and tortuous and are called as corkscrew or sawtooth glands. So these vacuoles, after 2 to 3 days, that is after 22 days, in case of regular 28-day cycle, because corpus luteum activity is on maximum day 22. So after 22 days, it will become heavy and tortuous glands, and it will be called corkscrew or sawtooth glands. So this is the late histological feature of the secretory endometrium. Secretory. Okay, by mistake I did say here secondary. It is secretory endometrium. This is why the early half of the cycle before ovulation is called as proliferative, and the late half is called secretory phase, because it is providing nutrition. So it's like a secretion. Now, vasodilation. Increased blood supply to endometrium will cause, happens because the progesterone is a smooth muscle relaxant. So it will dilate it, and vasodilation will be here and there, and if there is a vasodilation, more blood will flow, and it will flow to the endometrium. So increased blood supply to the endometrium. So basically, all of this is preparing for the pregnancy. And this increased blood supply, if there is no pregnancy, it will shed, and the blood will be discharged in form of the menses. Okay, now anti-proliferative effect. Activity of corpus luteum is maximum on day 8 post-ovulation, right? Level of progesterone is also maximum on day 8 post-ovulation. Why? Because after that there's a negative feedback to LH. LH basically finishes off, and then there is no support to the corpus luteum, and corpus luteum is it starts decreasing the amount of progesterone which is being secreted, right? It's all a cycle. And the level of progesterone is maximum date post ovulation, and how much it is more than equal to 3 nanogram per ml. So if this much at least amount is required to give negative feedback to LH. Now one more addition we got, right? We'll repeat. LH surge was 36 hours prior to ovulation, and when it is occurring, when minimum estradiol is at least 200 picogram per ml for at least for a period of 48 hours. LH peak was 10 to 12 hours prior to ovulation, and how much LH is required for ovulation? 75 nanogram per ml. Then now we have progesterone. Progesterone is more than or equal to 3 nanogram per ml. So for negative feedback to LH, okay. LH maximum for max was 75 nanogram per ml. For giving negative feedback to LH, it is 3 nanogram per ml. For causing LH surge, how much estradiol you required? 200 picogram per ml for a period of 48 hours. And when is LH surge happening? 36 hours prior ovulation. Like, keep revising. Okay, now corpus luteum degenerates. The degenerate is known as albicans white. Okay, so now if corpus luteum degenerates, all the hormone which is being secreted degenerates, progesterone, estrogen, inhibin. Progesterone is a progestational hormone, like it's preparing for the pregnancy. If fertilization is not occurred, corpus luteum will die. Time of ovulation is detected by urine LH, serum estradiol, BBT. What is BBT? It increases at the time of ovulation, not FSH and HCG. Not FSH and HCG. So the time of ovulation is detected by LH, estradiol, because we all studied about the LH only. LH surge was happening 36 hours prior ovulation. So everything is related to ovulation is with LH only. Estradiol required at least 200 picogram per ml for at least 48 hours for LH surge to occur. And then LH peak is the amount LH peak is 75 nanogram per ml. So all of us we were talking about was LH. Now one thing is BBT. BBT increases at the time of ovulation. BBT is basal body temperature, which increases at the time of ovulation. Okay. Now events which leads to due to decreased what happens when progesterone decreases, what will happen? So it will no longer able to hold in the endometrium will shed. Vasoconstriction will occur because progesterone obviously was causing vasodilation, and this will cause further shedding of the endometrium. Once vasoconstriction will occur, it will lead to the secretion of PGF2 alpha, and also there will be release of metalloproteinase enzyme which causes ischemic necrosis of the endometrium. Okay, so this ischemic necrosis might sound pathological, but it is not pathological. It's just an apoptosis and it's a physiological process. Ischemic necrosis is not pathological. Okay, so low progesterone causes vasoconstriction of spiral arteries due to loss of vasodilatory support. It leads to ischemia, reduced blood flow in functional layer of endometrium. Now PGF2 alpha is increased. Why? Because of vasoconstriction. Progesterone normally inhibits phospholipase A2 and COX enzyme. Progesterone normally inhibits PLA2 and COX enzymes. When progesterone drops, PGF2 alpha synthesis increases. Okay. Now what is the PGF2 effect? It is a potent vasoconstrictor. It causes myometrial contraction. There will be cramps. That's why during menses we have cramps due to PGF2 alpha effects. That is why we take NSAIDs which inhibits prostaglandin. So, and PGF2 alpha will cause further ischemia, which will cause endometrial breakdown and menstrual bleeding. So there are two things: vasoconstriction of spiral arteries due to loss of vasodilation and ischemia. PGF2 alpha, why? Because progesterone normally inhibits COX enzymes and phospholipase A2 enzymes. And when progesterone drops, PGF2 alpha synthesis increases. Okay, and it will cause further myometrial contractions. Okay, so what did I say? Metalloproteinase enzyme causes ischemia. And it is apoptosis, it's not pathological. So there will be expulsion of endometrial shedding. It will be now expulsion will be by myometrial contraction or endometrial peristalsis, which is by PGF2 alpha. Because vaginal opening is narrow, so endometrial tissue is converted into blood via fibrinolytic system of endometrium. So blood comes out via myometrial contraction or endometrial peristalsis, not the endometrial tissue. So what happens? Fibrinolysis occurs via fibrinolytic system. So blood comes, and which blood it is? Mainly arterial blood. Mainly arterial blood. Menstrual blood is mainly arterial blood. Menstruation is apoptosis, not a pathological process. A lady gets regular monthly vaginal bleeding due to fall of progesterone. Even it's due to fall of progesterone, estrogen and inhibin A, because as we studied, the corpus luteum is also secreting estradiol and inhibin A. So what will happen? We remember that estradiol and inhibin A was giving negative feedback to FSH. So there will be no one to give negative feedback to FSH. So FSH will increase, and now follicular growth for the next cycle will begin. Now we have 4 types of natural estrogens. E1 is estrione 1, estradiol is E2. Estrione is from aromatization. Aromatization was occurring in granulosa cells due to FSH, not due to LH. E2 is estradiol. It is main in the reproductive age in either pregnant or non-pregnant, and it is the most potent as well. All the reproductive ages, whether the woman is pregnant or non-pregnant, estradiol is high. Like in most of the females, in us, it is estradiol which is high. Okay. Now E3 estriol, it is only during pregnancy, which is synthesized by placenta using DHEA and DHEAS. So estriol is during pregnancy, and tetriol is also during pregnancy. हम दो हमारे दो, ये हम दो हमारे एक. Okay, so triol and tetriol, it is synthesized by placenta, and it is for during pregnancy. It's specific to pregnancy, E3 and E4. Okay, now E3 is more than E4. If E3 is more than E4, it may be taken as a marker of fetal well-being. Okay, so to decrease population, we need hum do hamare ek, not hum do hamare do. Oh, it's outdated now. So for it is a marker of fetal well-being, because fetus will be more nourished if there is one child rather than two. Just a way of learning. Okay, maximum amount of estrogen in productive age is E2. Maximum amount of estrogen in menopausal lady is E1. E1. Now she's alone. Now before ovulation, E2 is secreted from granulosa cells. Estradiol is secreted from granulosa cells. And after ovulation, estradiol is secreted from corpus luteum. We did discuss this, that corpus luteum now secretes estradiol, but this time it secretes inhibin A, and granulosa cell was secreting inhibin B along with estradiol. Okay. Now we have most potent estrogen is ethinyl estradiol, which is a synthetic estradiol. Then we have conjugated equine estrogen. Equine is horse estrogen. Then we have E2, E1, E3, E4. Okay, E2, E1, E3, E4, and E3 is greater than E4 in pregnant. It is a marker of fetal well-being. Most important hormone responsible for menstruation is progesterone, because fall of progesterone only leads to menstruation. Now first half we already discussed this. Secretion of glycogen and lipids. Okay. The vacuoles was there. Now Mittelschmerz is a mid-cycle pain which occurs due to ovulation. Okay, mid-cycle, at the time of ovulation, sometimes some women have pain. Mittels means middle, and Merz means pain. So it's Mittelschmerz pain is mid-cycle pain which occurs due to prostaglandins. So pain most of the time is due to prostaglandin itself. Like in this also, the pain was due to prostaglandin. PGF2 alpha was causing contraction of myometrium leading to pain. Reason of pain is prostaglandin release causes pain, and then when follicles rupture, blood vessels around follicles, which is known as perifollicular blood vessels, also ruptures. Then this blood goes into pouch of Douglas, which is the rectouterine pouch or Cul-de sac or rectouterine fold of peritoneum. There is an irritation here. When the blood goes into that due to gravity, it can also cause pain. It is mainly due to PG release, but sometimes also due to the perifollicular blood vessels rupture. Okay. So what will be the advice if a woman comes? Do ultrasound. If everything is normal, just reassure the patient that it's a normal thing. Now there is a mitral blue. T is silent. Okay, mitral blue. It's a mid-cycle spotting due to ovulation, and there is we'll see minimal bleeding per vaginum. So what happens is some blood from rupture of the perifollicular blood vessels. So earlier when it was entering the pouch of Douglas, it was causing pain. But what happens sometimes, it enters the tube and then comes out of the vagina and causes spotting. Okay, so it comes here and it goes down and causes spotting. Now it's a very, very, very rare condition for this to occur. And again, what you'll do advise ultrasound. If it's normal, just reassure the patient. But sometimes the bleeding is too much, then what do? You give antifibrinolytic drugs, which such as tranexamic acid, which prevents clot formation. There's it comes in tab Tranexa, 500 mg comes, you give that to the patient, but it's very rare. Now we have premenstrual tension or premenstrual syndrome. This is now a pathological condition. The Mittel's merz and Mittel's blue was a physiological condition. Now this is a pathological condition, which is a premenstrual tension or syndrome, PMS. So it occurs approximately 5 to 10 days before menses. Now what happens in this is there is a bloating sensation in the body. Most commonly it is breast engorgement happens. Why this happens? Due to some fluid retention. There will be nervousness, there will be mood swings, there will be palpitations. If all of these are occurring to you, just remember that this is pathological and we should go and seek doctor's help, because the breast engorgement and all of that is not a physiological condition, and it occurs 5 to 10 days before menses. Many of the females experience this premenstrual syndrome. Now the most common cause is idiopathic, and sometimes it can be due to low serotonin. So if it is a low serotonin condition, the drug of choice will be fluoxetine, which is an SSRI, selective serotonin reuptake inhibitors, fluoxetine. So what are the drugs which are SSRI? Paroxetine, fluoxetine, fluoxamine, escitalopram, citalopram, like all of these are SSRI. So PMS can also be due to low serotonin, because if you know, SSRI is an antidepressant drug. So all of these mood swings, nervousness and palpitations are signs of depression, right? So it can be due to low serotonin, and so the management is SSRI. Now best time to do breast self-exam is day 3 post menstruation, and most common cancer in female is breast cancer. And if just a little bit correlation with PSM, most common cancer in male is lip cancer more than lung cancer. And if they ask you in general the most common cancer overall, irrespective of the male and female gender, it is breast cancer. So best is day 3 post ovulation. Few things to remember is that day of ovulation can be fixed. Just remember cycle length minus 14 days. So what do we understand is that the progesteronic days is fixed of 14 days. The ovulatory phase the estrogenic phase can vary, but the progesteronic phase does not vary. Then second half cycle of cycle is fixed. Okay, so in case if you have 32-day cycle, just minus 14, it will be 18. Then we have normal parameters according to FIGO classification. So cycle length and frequency, normal is 24 to 38 days. 24 to 38 days is normal. This frequency is fine. Amount of blood loss in single episodes of menstruation is 20 to 80 ml. So mean blood loss is 30 to 50 ml. Mean blood loss is 30 to 50 ml. Duration of bleeding is 2 to 8 days. Approx of mean is 4.5 days, 5 days. Mean cycle length is 28 days, the one which we commonly use, but the frequency is 24 to 38 days. Now cycle to cycle variation can be up to 20 days. But the new proposal of the cycle to cycle variation is only 7 to 9 days. So what do we mean by cycle to cycle variation? For example, you get your menses on 5th June. Then you got on 5th July, then you got on 5th August, then you get on 5th September plus 20. Okay, so up to 25th September bleeding is okay, fine, it's a regular cycle. But if it happens after 25, like the cycle to cycle variation is more than 20 days, then it is an irregular cycle. But the new proposal is only 7 to 9 days. Now menarche is onset of menses, menopause is cessation of menses. Reproductive period is period between menarche and menopause. Age of menarche is 10 to 15 years. Mean is 12.5 years. Now